Good morning, dear students. Today we are going to discuss a highly practical and life-saving concept in maternal and child health nursing called microbirth planning. At first hearing, this topic may sound like simple paperwork or a government record, but in reality it is much more than that. It is a carefully designed safety strategy that helps us protect the life of mother and baby during one of the most critical periods of life, that is childbirth. We all know that pregnancy is usually considered a normal physiological process, but labor can turn into unpredictable event within minutes. A mother who appears completely normal in the morning may suddenly develop obstructed labor, fetal distress, and severe bleeding and convulsions by the night. So in India, according to recent maternal health monitoring reports, a significant proportion of the maternal deaths still happen because the women do not reach the proper care on time. So the problem is often not only the disease but the delay as well. Microbirth planning directly addresses this delay by preparing every step beforehand. It is similar to preparing an evacuation plan before a fire accident. We do not wait for the building to burn and then think about the exit. Likewise, we do not wait for the labor pain to start and then arranging for the money, transport, and hospital. So, as future nurses, this topic is very important because nurses are the bridge between community awareness and hospital safety. Myself, Ruth Kezia, Assistant Professor in Triple M College, MMM College of Nursing. Before entering into the content, let me briefly tell you what are we expected to learn from this session. By the end of this class, you should be able to understand the concept, meaning, and public health importance of microbirth planning. You should be able to define it clearly, explain the uh, government scheme connected with it, list the components involved, describe how counseling is done for mother and families, and finally explain the process of preparing microbirth plans, especially for high risk pregnant women. So today's session is not just for exam writing, it is for the field application. Imagine that tomorrow you are posted in a village as a community health nurse and a pregnant woman in her 8th month asks you, "Sister, what should I do before my delivery?" Then this lecture should help you understand and answer the question in a complete and organized manner. In simple terms, our objective is to learn how to convert an uncertain pregnancy into prepared pregnancy. Okay, because when preparation increases, the panic will decrease. When the panic decreases, the response becomes faster, and when the response becomes faster, the maternal and the neonatal survival improves. So that is the practical objective behind this topic. Now let us begin with the introduction. A birth microplan is a structured tool used to systematically record all the important details of a particular pregnant woman for birth preparedness and complication readiness, shortly called as BPCR. Birth preparedness means getting ready for normal delivery, and complication readiness means being ready if any danger suddenly occurs. This plan is prepared by frontline health workers such as CHO, which means community health officer, ANM, meaning auxiliary nurse midwife, in close discussion with MPW, meaning multipurpose worker, and also with the family. So this is not an individual plan made by the woman alone. It is a coordinated family health system plan. This planning is usually done under a government maternal welfare scheme called JSY, that is Janani Suraksha Yojana. The purpose is very clear: reduce maternal mortality and neonatal mortality by promoting timely institutional care. Here I want you to remember one public health fact, that is, many maternal deaths do not happen because of the complication is untreatable. They happen because the treatment comes too late. A woman bleeds, The family gets frightened, then they search for money, search for vehicle, ask the neighbors which hospital is open, and by the time she reaches care, the golden hour is lost. So the microbirth planning works exactly against this chain of delay. It acts like a preloaded emergency response file. Microbirth planning, also called as birth preparedness plan, can be defined as a birth plan drawn up in advance by ANM, that is auxiliary nurse midwife, for each pregnant woman in order to prepare the woman and her family for any unforeseen complications and thereby prevent maternal morbidity and mortality caused by delays. Let us understand this in simple practical language. The most important words in this definition is drawn up in advance. Okay, that is an important word. Why? Because childbirth emergencies do not give appointment dates. Okay, severe labor pain, ruptured membranes, postpartum hemorrhage, convulsions, these conditions can happen unexpectedly. If the family begins planning only after the emergency starts, valuable time is wasted. So it is exactly like, writing an exam without carrying a pen and then borrowing from 10 people after the bell rings. You may still write, but you already lost time. In obstetrics, this lost time can mean lost uterus, lost baby, or lost mother. So therefore, microbirth planning is actually a delay prevention model. It prevents the first delay, that is delay in decision making. It prevents the second delay, that is delay in reaching health facilities. And it prevents the third delay, that is delay in getting appropriate referral. So this definition may appear short in textbook, but clinically it means advanced survival planning. I hope you got the definition of microbirth planning. So what is JSY and how it is connected to microbirth planning? Now let us understand the government backbone behind this concept, which is JSY, Janani Suraksha Yojana. Janani means mother, Suraksha means protection or safety, and Yojana means scheme. So this is literally a mother safety scheme launched by Government of India. It is a centrally sponsored program aimed at promoting institutional delivery among poor and vulnerable pregnant women by providing cash assistance during delivery and post-delivery period. Why did the government feel the need for such a scheme? Because earlier many women, especially in rural and economically weaker sections, preferred home delivery due to poverty, transport issues, and traditional beliefs. But home delivery without skilled assistance attendant increased maternal death and newborn death and infection. Therefore, JSY not only motivates the woman financially but also links them to the healthcare system. Now, where does this microbirth planning fit into this JSY? Think of JSY as an engine and the microbirth planning as the steering wheel. The scheme provides support, but microbirth planning shows the exact direction. Which hospital, which date, which vehicle, which referral center, which documents, which contact person, and so on. Without planning, even a good scheme may not reach the woman effectively. Hence, microbirth planning is considered an integral operational component of JSY. It turns the government policy into bedside reality. After understanding the concept and its policy background, the next important area is the components of microbirth planning. Students, remember one thing: a safe delivery does not depend on one single action. It depends on a chain of small preparation done correctly. Just like a parachute has many strings, but all strings together ensure a safe landing, right? Same way, microbirth planning also has a multiple components and each one supports maternal safety. If one component is weak, the entire preparedness becomes incomplete. Broadly, the major components include registration of the pregnant woman, informing her about the antenatal care schedule and immunization, identifying the place of delivery, choosing a skilled birth attendant, selecting a referral facility, arranging transport, and ensuring financial readiness. These may sound like administrative tasks, but In community obstetrics, these are the actual mortality prevention tools. Recent Indian maternal care reviews shows that one of the recurring reasons for maternal death is the lack of birth preparedness, prior birth preparedness. This means the mother was not medically ignored, she was practically unprepared. Therefore, every component in this list should be as seen as one protective wall around the pregnant woman. The stronger the walls, the safer the mother. The first and the foundational component is registration of the pregnant woman. As soon as the pregnancy is confirmed, ideally in the first trimester, the woman should be registered under the health system. During this time, the health worker fills the maternal and child protection card, the Janani Suraksha Yojana card, and collects other relevant documents such as below poverty line certificate, Aadhaar details, or any other local eligibility proofs. Why is this registration so important? Because from this moment onward, the woman enters the official maternal surveillance system. In simple words, she becomes a tracked mother, not an invisible mother. Her hemoglobin level, blood pressure, obstetric history, and immunization status and expected date of delivery, and if there are any risk factors, all are documented. Imagine a parcel without an address label. It goes anywhere, right? Nobody knows where it is going, where it should go. Similarly, an unregistered pregnant woman may miss the government benefits, or she may miss the follow up or timely referral. Registration also helps in continuity of care. Even if she goes to another center, the record will speak for her. As nurses, you should know and understand the proper documentation is not just an illegal formality, but in maternal care, the documentation is communication, continuity, and protection. We'll move on to the component 2, that is informing antenatal visits, TT injection schedule, and EDD. Once the registration is complete, the next step is educating the woman about her follow-up schedule. She should be clearly informed about the dates regarding antenatal care visits, schedule for tetanus toxoid injections, and her EDD, that is expected date of delivery. Let us understand why each of these matters. And antenatal visits are periodic health assessments where we monitor the mother's blood pressure, body weight, urine sugar, fetal growth, fetal heart rate, and signs of anemia or any swelling or edema. Many complications like gestational hypertension or gestational diabetes, oligohydramnias, or even a intrauterine growth restriction, it will not produce obvious symptom in the early stages. Only a regular antenatal visits will help us to detect them. TT injection protect the mother and the baby from tetanus, which is a deadly but preventable disease infection. And the expected date of delivery acts like a countdown clock. It helps the family to prepare them mentally and logistically for the childbirth. If you know your examination date, you will prepare for your exam accordingly, right? If you don't know the date, the preparation becomes very careless and you may miss the exam also. Similarly, informing the EDD creates the alertness in the household. Therefore, this component is all about keeping the woman informed about her pregnancy, monitor, and medically connected throughout the pregnancy period. The third component is one of the most critical component in this microbirth prepare planning. Okay, that is identifying the place of delivery and the person who would conduct the delivery. The third component is one of the most critical, and this decision should never be left until the onset of labor. That means you should not take the decision after the pain comes. Okay, all pregnant women should be strongly encouraged for institutional delivery, meaning childbirth in a hospital or primary health center or community health center or any recognized maternity facility. Why is institutional delivery preferred? Because labor is one of the most deceptive phase in obstetrics. A woman may have 9 months of apparently normal pregnancy and still develop a sudden fetal distress or meconium strain like prolonged labor, retained placenta, or severe postpartum hemorrhage within hours. At home, there may be emotional support, but emotional support cannot provide you oxygen. It cannot provide you IV fluids, blood transfusion, suction machine, and neonatal resuscitation. Therefore, the delivery site must be selected in advance. Along with that, the family should identify a SBA, that is skilled birth attendant. So what we are saying is, under this component you should understand you should answer two questions, that is where is the delivery and who is going to conduct the delivery. So where means the institution. The who, under the who question comes the skilled birth attendant. A skilled birth attendant means a trained professional such as staff nurse, auxiliary nurse midwife or doctor who knows how to conduct normal delivery and recognize complications early. This is similar to choosing an experienced pilot before air travel. You may pray for a smooth journey, but you still need a trained pilot, right, in case of any turbulence. So same way, the who question and the where question of conducting delivery should be answered under this third component. Now let us move on to the next layer of safety, that is referral planning. Even after selecting a delivery place, we must ask one more question. What if that center cannot handle a complication? This is where identifying a referral facility becomes essential. A referral facility means higher center equipped with advanced obstetric emergency care such as blood transfusion, cesarean section, intensive monitoring, and specialist consultation. This may be a FRU, that is first referral unit, district hospital or medical college hospital. Why should this be pre-identified? Because emergencies in obstetrics are time sensitive. If the mother develops eclampsia, severe antepartum hemorrhage, or obstructed labor, or any kind of fetal compromise, there is no time for family discussion. That is, the decision and the route should already be ready. The decision and the route, okay, should already be ready, and along with identifying the facility, the exact mode of referral should also be planned. That is, who will call, which ambulance number to use, which road route is faster, who will accompany the mother, and who will carry the documents. All these questions should be answered when you are planning for the referral facility and the mode of referral. Think of this having a second staircase in a building. We hope we never use the emergency exit, but if the fire starts, the emergency exit saves life, right? Same way, referral planning is like emergency exit in maternity care. Okay. The fifth component in the microbirth planning is arranging transport for the beneficiary, meaning the pregnant woman. Students, in maternal health care, there is one very painful reality you should know. That is, many mothers die not inside the labor room, but on the way to the labor room. Okay, this happens because the family decides to seek care but cannot reach the facility on time. This is called a second delay in obstetric emergencies. Labor pain may start at midnight, during heavy rain, or during any village festival, or in any remote place where the public transport is not available. Okay, in such situation, if there is no vehicle has been pre-arranged, the panic will begin. The family members will start calling the random drivers. They will bargain for the autos. They will may wake the neighbors who are around, or they will wait for the ambulance response. Meanwhile, the mother will bleed, and the mother may start convulsing or deliver, or she may deliver on the roadside. So therefore, transport should be arranged in advance with the written clearly in birth plan. Okay, this includes ambulance numbers such as 108 service or private jeep contacts or local auto drivers, panchayat vehicle, or even known villagers who owns any kind of transport. The family should know exactly whom to call first. I often compare this to keeping a fire extinguisher in a building. During fire, you do not start searching for a water bucket. Okay, likewise, during labor, you should not start searching for a vehicle. Okay, so the planned transport converts this emergency movement into a controlled movement. The next component is making sure that funds are available to the ANM or ASHA. The sixth component is, basically ensuring financial preparedness. Here, ANM means auxiliary nurse midwife and ASHA means accredited social health activist. Okay, though many government schemes provide incentives and free services, practically some immediate expenses still arise during childbirth. The expenses may be like transport charges, food for the attenders, medicines which we are buying from the outside stock, or emergency diagnostic test, referral movement, or temporary admission expenses. In many low income households, even a small sudden amount can create hesitation. The husband may say, "Let us wait till morning." Or the family may spend 1 hour in trying to borrow money from the relatives. That 1 hour can become fatal. Therefore, the health worker should encourage the family to either keep a small emergency delivery fund or ensure that government assistance under Janani Suraksha Yojana and related schemes is received on time. Financial planning in pregnancy is similar to charging your phone. Financial planning in maternity is related to, it can be compared to like charging your phone, charging your power bank for your phone before travel. You may hope not to use it, but if the battery drains, that backup becomes the difference between connection and disconnection. In the same way, emergency money becomes the difference between timely referral and dangerous delay. So, as nurses, never underestimate the role of economic counseling in maternal survival. Now, after discussing the technical components, we must understand the soul behind all these components, that is, counseling. Microbirth learning cannot succeed by just filling the forms alone. The pregnant woman and her family should truly understand why each preparation is important. This understanding is created only through repeated counseling. During counseling, the nurse or health worker will explain the need for early registration, regular antenatal visits, TT injections, expected date of delivery awareness, hospital selection, emergency contacts, and family support. But counseling should not be done in a commanding tone. It should be done in a relatable and practical tone. For example, instead of simply saying, "Come for checkup," we can explain that some pregnancy complications are silent like termites inside a wood. The outside may look fine, but damage may already be happening. Such analogies helps the families understand the hidden risks, and counseling should also include husbands, mother-in-laws, and other decision makers, because often the pregnant woman alone does not take emergency decisions in rural families. So repetition is essential. Just as we water a plant regularly for growth, we must reinforce counseling at every antenatal visits for behavioral change. A well-counseled family becomes cooperative instead of confused during labor. So first is Birth Preparedness Foundation. Here we concentrate on the registration for fill the maternal and the child protection card during first antenatal visits and visit schedule. Inform the woman regarding the subsequent visit dates and emphasize timely attendance and the skill provider. Help the identify SBA for delivery and considering all relevant factors. Institutional, the next topic under counseling is institutional delivery, why it's recommended. So this slide emphasizes on institutional delivery, and there is a reason for this repeated emphasis. Institutional delivery means childbirth in a healthcare institution where trained professional emergency medicines and sterile equipments and newborn care facilities are available around the clock. Every pregnant woman must be encouraged to choose institutional delivery because obstetric complications are often sudden and unpredictable. Let me give you a simple scenario. Suppose a woman is having normal labor at home, but after the baby is born, she starts developing severe postpartum hemorrhage, meaning heavy bleeding after delivery. Within minutes, her blood pressure can collapse. At family members can only cry and panic, but in a health facility, oxytocin can be given, intravenous fluids can be started, uterine massage can be done, and the blood can be arranged. And if she needed, she can be shifted to the operation theater. This is the difference between unassisted crisis and managed emergency. According to the recent maternal health data, institutional delivery have significantly contributed to the reduction of maternal mortality ratio in India over the last decade. So, institutional delivery is not merely a government recommendation, it is a proven evidence based survival strategy. We can say home delivery may offer comfort, but still, institutional offers controlled safety. However, in community practice, we must also face reality. Despite repeated counseling, some women still choose home delivery. This may be due to the cultural customs, fear of hospitals, financial misconceptions, elder family pressure, or long distance from the facilities. In such situations, the role of the nurse is not to abandon the mother, but to reduce the risk as much as possible. The mother should be applied with DDK, that is disposable delivery kit. This kit contains sterile blade, cord tie, clean sheets, soap, gloves, and other basic sterile items. In addition, the family should be taught the six cleans, that is clean hands, clean delivery surface, clean cord cutting instrument, clean cord tie, clean umbilical stump care, and clean perineum. Why are these six cleans important? Because infections after home delivery can silently kill both mother and the baby through sepsis and neonatal tetanus. Even if home delivery is planned, records should be maintained and continuous counseling should be done in subsequent visits to again motivate for institutional delivery if possible. This situation is similar to a patient refusing hospital admission. Even if refusal happens, we still give first aid and danger instructions. So, in nursing practice, refusal of ideal care does not mean withdrawal of supportive care. We will move on to the next slide, that is essential home delivery items. If home delivery is unavoidable, then the environment and the materials should be made as safe and organized as possible. Home should not become a careless place of delivery. It should temporarily function like a basic clean birthing unit. Certain essential items must be kept ready. First, a trained or at least skilled birth attendant should be present. Next, the maternal and the child protection card should be available because it contains all antenatal information, blood group, risk notes, and immunization details. Clean towels are required for immediately drying and wrapping the baby because wet newborns lose the body heat very quickly. Emergency medicines such as oxytocin and misoprostol should be available to prevent postpartum hemorrhage, which is one of the leading cause of maternal death. Sterile knife or sterile blade and cord clamps are needed for safe cord cutting. The room should be dry, clean, and comfortably warm because cold environment increases the risk of neonatal hypothermia. Drinking water and light food should also be kept ready for mother and support person. So this slide teaches us that if a delivery happens at home, preparation should still imitate hospital principles, that is cleanliness, warmth, sterility, emergency readiness. In short, even when resources are limited, planning should never be limited. We will move on to the next slide, that is recognizing labor signs. Another highly important aspect of counseling is teaching the woman and her family to recognize the early labor signs. Many families, especially first time mothers, fail to identify when true labor has started. They may mistake labor pain for ordinary abdominal discomfort and continue to wait at home. Therefore, nurses must explain the common signs clearly. One sign is bloody, sticky vaginal discharge, commonly called as SHO, which indicates cervical changes. Another major sign is regular uterine contractions that gradually increase in duration, frequency, and intensity. There may be also low back pain, abdominal tightening, and rupture of membranes or leaking of fluid. Families should be advised that once these signs appear, they should either go to the health facility or inform ASHA immediately. Labor signs are like a first warning siren before a cyclone. Once the siren starts, people do not continue normal activities, they move to safety. In the same way, once labor signs begin, the mother should move into active preparedness mode. Early recognition prevents last minute roadside deliveries, panic, and delayed admission. The next slide is referral transport, locating health facilities, building support networks, and financial schemes. So this slide teaches us one of the most important principle, that is childbirth is not handled by mother alone. It is handled by a support system. First, the woman and the family must know the nearest PHC, that is Primary Health Center, and FRU, that is First Referral Unit, where emergency obstetric care is available 24 hours. Contact numbers, landmarks, and routine details should be clearly known. Second, the transport should be linked to this facility, like ambulance, private vehicle, or a community support vehicle. Third, a support network should be built around the pregnant woman. This includes close relatives who can accompany her. That is ASHA worker, AWW, that is Anganwadi worker, neighbors, blood donor if needed, and someone to take care for other children at home. In addition, financial schemes such as Janani Suraksha Yojana, transport assistance, and state maternal welfare benefits should be discussed and accessed. I usually explain this with one analogy, that is, a mother in labor is like a patient entering an operation theater. She should not enter alone without a prepared team outside. Every person should have a role. One calls the ambulance, one carries document, one arranges money, one accompanies, one informs the health worker. When support is distributed, burden is reduced. This team preparedness dramatically lowers the emergency confusion. This we explained in the previous slide itself, that is locating the health facility, it may be a PHC, or primary health center, or the first referral unit. Then we explained about the transport system. Okay, building your support networks like family members, transport arrangements, ASHA, financial support, and childcare. We also completed about explained. I also explained about the financial planning and the government schemes, where that should be ready in hand. Okay, for the mother during for the to use in the emergency time. Next, we'll move on to the most sensitive group, that is HRP, meaning high risk pregnancy women. These are the mothers who have conditions such as severe anemia, pregnancy induced hypertension, gestational diabetes, previous cesarean section, multiple pregnancy, malpresentation, heart disease, teenage pregnancy, elderly pregnancy, or bad obstetric history. Okay, for these women, routine birth planning is not enough. Intensified birth planning is necessary. Once identified by ANM, that is auxiliary nurse midwife, or the CHO, community health officer at the subcenter, or HWC, that is health and wellness center, a HRP, a high risk pregnancy follow up card is issued. Okay, the woman is tracked according to her EDD, that is expected date of delivery, and monitored more frequently. The family is counseled to open a bank account in the mother's name to receive any government facilities. Okay, to receive any government benefits and also to save emergency funds. And resistant families are counseled repeatedly by resistant counseling families are counseled repeatedly by the specialist support team. Minimum three antenatal checkups by a gynecologist or a medical officers are ensured under enhanced maternal service programs. In remote places where 108 ambulance cannot reach, even local villages with vehicles or boats are pre-identified. Why this extra caution? Because high risk mother is like a patient walking on thin ice. One small slip can become a major crisis. Therefore, surveillance must be tighter and referral must be faster and the family alertness must be higher. Family birth preparedness. Students, please remember this statement. Safe motherhood, never an individual event. It is a family supported event. Every pregnant woman should be helped to develop a family birth preparedness plan that includes facility selection, transport readiness, important mobile contact numbers, government entitlements, identification of the accompanying relative, and even a potential blood donor in case blood transfusion becomes necessary. Family members should also be made aware of all the danger signs during pregnancy, such as swelling, severe headache, bleeding, reduced fetal movement, fits, or leaking. Why is this family involvement so important? Because during an emergency, the mother may be in pain, frightened, or physically unable to make decisions. At that time, the family members becomes the decision making unit. If they are informed, action is immediate. If they are ignorant, action is delayed. This is why birth preparedness and complication readiness are considered cornerstones of modern antenatal care. In conclusion, microbirth planning is not merely a form to be filled. It is comprehensive maternal survival blueprint. It anticipates problems before they occur and it organizes the resources before they are needed and transforms fear into readiness. As future nurses, when you prepare a microbirth plan, mm, as futures nurses, when you prepare a microbirth plan, you are not just writing notes on paper, you are building a protective shield around two lives, that is the mother and the baby. So, thank you, students. I hope this session helped you understand that childbirth safety begins long before labor begins. Labor begins. A well prepared birth plan can convert a possible tragedy into a safe motherhood success story. Thank you all.